Eldien, are you ready?
Yes, I'm ready.
Yes. You may start.
Okay. Good afternoon, everybody. It's really a nice chance to try this. I would like to thank the Middle East Spine Society, Professor Zerili, and Dr. Umar Yaman for their effort to bring this new technology into applications. Thoracolumbar fractures and its surgical management. If we look at spinal column injuries constitutes about 3% of all trauma cases. And we have to consider that about 20% of these patients have a neurological deficits. And 75% of the spine injuries occur in the thoracolumbar segments. And this happens almost always mainly in youngs. About 5% of these fractures are non-contagious fractures. And associated non-spinal injuries exists in about 60% of the patients that we should put into considerations. Really, the field of spine surgery is growing because of the advancement in the diagnostic imaging and the better understanding of the spinal biomechanics, in addition to bone growth physiology. The surgical concepts progression is really going very fast. And the development of spinal instrumentations, tools, and technology advancements is amazing too. But at the meantime, you have to see that you have a high patient expectations from you. So every patient is looking for complete cure, which is a burden on the surgeon. If we look to the thoracolumbar regions, it constitutes it includes the lower dorsal vertebrae and the first lumbar one. It has anatomical considerations because the canal cord ratio is relatively narrow. In addition to anatomically diaphragmatic attachments. And biomechanically, it represents a transitional zone where the thoracic, the junctional area between thoracic kyphosis and the lumbar lordosis. And at the same time, the most affected levels is first lumbar vertebrae, as we can see here. And the mechanism of trauma mostly is a fall from a height. And this is followed by motor vehicle accidents. And as we see here, the facets are oriented coronally in the dorsal spine, but sagittally in the lumbar spine. In the thoracolumbar region, it is oblique. The assessments always starts with ABC as usual, airway, breathing, and circulation. In addition to immediate immobilization of the patients, we have to insist also on taking the history, which elicits to us the mechanism of trauma. Complete neurological examination, including motor, sensory, and this should be repeated because, as we all know, that trauma is a dynamic process. And we have to consider that about 70 to 80% of the patients has no neurological deficits. This is always followed by imaging of the patients that includes X-ray, CT scan, MRI, etc. But everybody should not forget associated injuries that should be recognized and properly treated. In addition to the shock, 3 types of shock that may exist, either hypovolemic shock, spinal shock, or neurogenic shock should be diagnosed. You have a lot of classification systems that for that region. The ideal one should be easy, should be applicable, should convey the information to everybody by an easy way and define the treatment plan. And it should monitor the patient progress from the neurological and the functional point of view. And it should be suitable as a research tool to follow up and to compare different techniques that may be utilized. We have assessment of the patient. We have American Spinal Injury Association ASIA score that may be starting from complete motor and sensory deficit, that's A, and ending with normal motor and sensory, that's E. In addition to Denis pain and work scale including P1, no pain, to chronic pain, to P5, which is constant severe pain with chronic pain medications. Work scale also should be recognized and should be done, including W1 with return to previous job, heavy labor and physical activity, to W5 with no work and completely disabled patients. If we look to the major mechanisms of injury, it may be compression, it may be rotation injury, it may be distractions, and most commonly it's a combination of any of these. Also, Denis three-column theory that divine the vertebral motion segments into the anterior column. The anterior column includes the anterior two-thirds of the vertebral body, the anterior annulus and the anterior longitudinal ligament. Middle column includes the posterior one-third of the vertebral body, posterior annulus and the posterior longitudinal ligament. The posterior column includes the posterior elements, pedicles, the facet joints, lamina, spinous processes, and the associated ligaments, supra and the interspinous ligaments and ligamentum flavum. Also, it's important to measure the anterior vertebral height. Anterior vertebral height is important to define the treatment plan between conservative and the surgical treatment and the other alternatives. And in addition to that, the canal compromise should be measured too. It can be measured either the anterior posterior diameter of the canal compared to with adjacent normal level, or the surface area occupied by the retropulsed bone, and there is softwares that measures the number of voxels which is specified to define that. The angles is important also, including a cup angle or the local kyphotic angle. If we look to Denis classification, he divides the spinal fractures into either minor injuries, including fracture of the transverse process, pars interarticularis, spinous processes, or major injuries. Major injuries including like compression fracture, as we see here, with anterior column failure, or burst fracture that includes the anterior and the middle column, whereas the posterior column is intact. Seat belt type of fractures that includes where the anterior column is intact and the middle and the posterior column is failed into distraction. And the last type is fracture dislocation with failure of all the three columns. And Denis defines that one column injury is stable, two or three column injury is unstable, and that's his definition of instability. McCormick Classification, he defined the fractures into compression comminuted, distraction fragment displacement, and multidirectional and translational angulation. McAfee Classification, he classified the fractures into wedge compression fracture, burst fractures that may be stable or unstable, seat belt fracture, flexion distraction injury, and the translational injury. The first type is wedge compression fractures, and he defined it that may be unstable if there is loss of anterior height 50% or more, or angulation more than 30 degrees. For unstable first burst fracture, if there is anterior height loss of the vertebral body 50% or more, angulation 30 degrees or more, or if there is associated fracture of the posterior structures, or if there is previous laminectomy of that patient. Seat belt fracture type, and all of it is unstable, but it may be including one level only, single level, or it may include two levels with fracture, of course, and the instability and the involvement of the three columns. Flexion distraction injury that may be ligamentous, or there may be retropulsed bony fragment ventrally in the canal. Of course, it's unstable too. Translational injury, the last type, is unstable. It may be shear type, flexion rotation type, or burst dislocation type. Going to the TLICS classification, which is really good advancement and the more mature classifications of the old ones. It involves the morphology of the injury and the fracture, including the integrity of the posterior ligamentous complex and the neurological status of the patients. As we can see here, injury morphology, it may be compression, burst, translational, or distraction, and they each have points, corresponding points. Posterior ligamentous complex injury either intact or disrupted, here 0, here 3. Neurological states either intact, nerve root injury or complete injury is given 2, and the incomplete injury is given 3. And this classification is very valuable to define the surgery. If the patient has 5 points or more, then this patient is unstable and should be operated upon. If he had 3 points or less, he can be treated non-operatively. And if he is 4 points, then this depends on the decision of the surgeon. And not only that, TLICS also determines the surgical approach. If the patient has incomplete neurological deficits plus anterior decompression, then the patient should be operated anteriorly. If the patient has incompetent posterior ligamentous complex, then he should be operated posteriorly. If there is neurological deficits plus incompetent posterior ligamentous complex, then combined surgery anterior and posteriorly should be done. So this classification again defined to us to operate or not, and what is the type of surgery. And the last classification system is OO alphanumeric system, which classifies these injuries into type A, that's vertebral body compression, either impaction or split or burst. Type B with anterior and posterior element injury with distraction, that may be ligamentous, bony, or plus anterior disruption. Type C, anterior and posterior elements injury with rotation, that's including the type 1, 2, 3. Of course, each of these types is going to have also more subgroups, and that's why I will not insist to go all through. Trauma instability scoring of Benzel is also important to be applied for this type of injuries. That includes loss of body height, loss of posterior column integrity, slip either during rest or in dynamic images, angulation deformity either at rest or in dynamic images, neural injury. And you calculate this. If the patient has 5 or more points, then we have here dominant instability, and this patient should be stabilized. The aim of treatment is to prevent neurological deterioration, minimize and to eliminate the spinal deformity through restabilization of the patients, and to ensure fracture healing and avoid the sequences and the complications of fractures and the adequate functional recovery, including the early relief of pain and the return to work. We have many options to treat these patients, either conservative treatment through bed rest, breathing and the medications and the other, or you can go to full surgery. Surgery may be posterior, may be anterior, may be combined, and it can be open or minimally invasive. And till now, there is controversy that still remain about the best alternative, although I will try to clarify the indication of each. And the selection of the management protocol depends upon if there is a neurological deficit or not. Is it incomplete or complete? Is it progressive or stationary or improving? And the amount of canal compromise and the extent of bony and ligamentous injury and if multiple levels injury exists or not, in addition to a deformity, and the pain status of the patient. Non-operative treatment can be advised for this type of injury, flexion compression fractures, in which the anterior column only is affected in the form of loss of height, with no canal compromised by any retropulsed fragments. And for burst fractures, if he is neurologically intact, with angular deformity less than 20 degrees, and the residual spinal canal is more than 50%, and the vertebral height loss, anterior vertebral height loss is less than 50%. These patients can be treated conservatively. And if we look here, that's a review article with thoracolumbar fractures without neurological deficits and the role of conservative treatment. There is a lot of researches which has been done. And this, at the end, the conclusion is non-operative treatment can be safely adopted in the management of thoracolumbar burst fractures with normal neurology, with the criteria that I mentioned before. And this paper, including a systematic review comparing operative and the non-operative treatment for thoracolumbar burst fractures in patients without neurological deficits. And the conclusions of this, that surgery may result in earlier mobilization and the hospital discharge, less initial pain, and the faster return to work. Although the final sagittal alignment is better maintained in patients who have undergone surgery, but vertebral alignment does not correlate with the outcome of the patients, either neurologically or from the pain or functional side. If we look to the available surgical techniques for this type of injuries, we have anterior approaches or antro-lateral approaches. We have posterior approaches, including translaminar approach, transpedicular approach, costotransversectomy, or lateral extracavitary approach. This is the available techniques that exist. But if we consider what is the ideal approach to be used, it should provide optimal exposure, it should be extensile, it should be anatomically based, it should be appropriate to the pathology, it should be safe with low morbidity, fast and simple. But you have to consider which approach to be used with the surgical skills of the surgeon and the familiarity with the approach and the available tools in your place and the facilities, in addition to the costs of treatment. And always we aim to do two things: either stabilization of the patient if there is instability, neural decompression to revert neurological deficits that may exist. The posterior approach is very attractive to neurosurgeons because of the familiarity with this approach, and it can be rapidly performed, and it avoids the complications that's always associated with thoracotomy and the anterior approach. And it is indicated and really beneficial for embedded laminar fractures, and if intraspinal hematomas exist for this type of fracture, and if there is posterior ligamentous disruption or fracture dislocation, and in addition, if there is multi-level involvement, either adjacent or not adjacent, and it can be utilized too for augmentation for anterior fusion and fixations. And the best way to do that is to put transpedicular screws 2 levels above and 2 levels below the fractured level. But short segment stabilization that includes 1 level above, 1 level below, and this will be discussed later. It can be done either open or minimally invasive percutaneously, and for canal clearance from the retropulsed bone fragment is relying on ligamentotaxis techniques, and for ligamentotaxis to be done, it relies on an intact posterior longitudinal ligament and the annulus, but it should be done for fresh fractures. But even so, if you are utilizing ligamentotaxis and the ligament is intact and it's a fresh fracture, reduction is partial, as we will mention later. That is the technique and how to be done. You insert the transpedicular screws and in convergence, in a slight convergence, and you make a distraction. And this, the anterior longitudinal ligament take the way to take this retropulsed fragment backwards, because also during the distraction you open a slight gap behind. In addition to that, canal clearance also can be performed if there is a loose fragment here inside the canal. Through an interlaminar window, you can go in and you can remove this retropulsed fragment. In addition to that, you can utilize bone impactors to hammer retropulsed bone back into its cavity and you cleave the canal. Transpedicular decompression is another technique to clear the canal from retropulsed bone here. And this can be done as you go through the pedicle and you remove the bone here and you push these retropulsed fragments into the cavity that had been created by fragment removal, and after that you can put here bone grafts. And this is a good technique to be utilized. However, the posterior approach with all these advantages does not totally decompress the canal, and the complete neurological recovery is questionable. And also there is some danger that if the posterior elements are intact, you may disrupt it. And to do perfect fixation, you require involvement 2 levels above and 2 levels below the fracture site. And if we look to the residual bone fragment inside the canal, many investigators have found that about 28 or 30% residual bone in the spinal canal after posterior instrumentation is left. And the significant canal remodeling occur with healing, clearing bone residual that's Wolff's law. And they recommend that if you find that the residual bone inside the canal is less than 25%, then you can continue conservatively for this and you can put the patient on thoracolumbar support. But if canal compromise is more than 25% or neurological deterioration occurs, then you have to go anteriorly again to remove this retropulsed bone fragment. And we should consider that the maturation of fusion versus instrumentation failure. Fusion needs time to be mature and take the job of stabilization. And at the same time, instrumentations had a definite number of cyclic loading, but ultimately it failure. So there is a race between both. So you have to ensure that you are using good instrumentation and making a good fusion so that your permanent stability is ensured for the patients. Some consider that the plants can be improved, can be removed, but aiming to preserve the mobile segment after fracture healing. But what is the indications for that, and what's criteria for, and after how long for this patient to remove the implants? This is still under investigations and not completely clear. The length of fixation systems that are to be utilized, short versus long segments. Short segments of course, provide significantly less stability than long segment fixation. And if you put a cross link to a short fixation, it improves stability only during the axial rotation. And by adding a screw at the fracture vertebrae, that's index screw, it improves the short segment stability by an average of 25%. That is the scenarios, the best scenario, 2 above, level above, 2 level below. If you would like to remove one, then you can 2 above and 1 below. And you may put an index screw at the fractures level, as I mentioned before. That is the short segment stabilization, 1 above and 1 below. With implant failure and the loss of correction, the possibility is up to almost 50%. And again, if you put index screw in the fractured vertebrae, you can add another 25% stability. And this normal level involvement and aids in fracture reduction and the kyphosis correction. Extra bear at the fracture segments, but what if you have, and what is common, the biblical is fractures, and also there is the question of safe path into the fractured body if it is comminuted, and this is a very nice technique. If you had a distal fragment and you like to put a transpedicular screw here in the fractured level, you can put a leg screw, take it back to its side, and you can put the transpedicular screw in the opposite direction, and the last one will be here. The need for anterior spacers, it can be needed, it will be needed if there is posterior ligamentous complex injury and the patient have persistent or progressive kyphus. What about multi-level, non-contagious spinal fractures? Stabilization system involving the primary fracture may affect the secondary fracture site when there is two levels or one level intact vertebrae in between. So you have to include it in your primary surgery. What about late post-traumatic kyphosis, like these patients that have L1 burst fracture and he is fixed here? And if we look, that is after 1 week, you can find that the angle of kyphosis is about 15 degrees. After 1 month, it becomes 27 degrees. After 3 months, it becomes 33 degrees. But after 1 year, it failed because it becomes 41 degrees. And most investigators advised that if the kyphosis is around more than 30 degrees, then posterior stabilization, the moment arm is great, and this will result in high tensile strength on the implant and the bone cage. So you may do pedicle subtraction, osteotomy, plus anterior support. But if the kyphosis is more than 60 degrees, then you can combine the anterior and the posterior stabilization, and diffusion is required. For the antro-lateral approach, we know that the anterior and the middle column carry about 80% of the body weight. And by assessing the spine anteriorly, there is a greater exposure of the anterior column, and this will avoid the back muscle dissection, and you can do effective distraction and deformity correction with adequate decompression of the spinal canal and foramina. At the same time, you can make a concomitant placement of interbody devices, bone grafts, and plating, and this will increase the likelihood of arthrodesis. In addition, manipulation and scarring of the neural structures are avoided. And lastly, and not the least, other stabilizing elements, including the lamina, the pedicles, or other tension bands, supra and interspinous ligaments are kept intact. You didn't did injury to it. Biomechanical facts is the anterior fusion and fixation is under compression, whereas posterior fusion is under tension loads. And considering that the stresses at the thoracolumbar junction is about 3-folds of the body weight, and the complete clearance of the spinal canal is mandatory to revert the neurological deficits, and this is only possible through the anterior route, and the effective neurological and the functional recovery can be ensured that way. And the selection criteria for the anterior approach, including if there is a neurological deficits, incomplete neurological deficits, including the motor and the sensory, and the radiographic evidence of mechanical instability in the form of loss of vertebral body height, 50% or more, or canal compromise, 40% or more, and the angulation kyphosis, 20 degrees or more. And the alternatives that's available for fixation, either short segment anterolateral fixations or you can do it combined short segment anterolaterally and posterior fixation transpercutaneous, or you can do extended anterolateral fixation including 2 levels above and 2 levels below. And very rarely that we utilize that, although biomechanically extended anterolateral fixation is comparable to combined anterior and posterior fixation. Always the patient in the left lateral position, and you flex the operative table, and you put, and the left side is utilized to avoid the liver and the inferior vena cava. And for your exposure in the rib interspace 2 levels above the level site of corpectomy, if you are operating on L1, then you put it at D12, D11. And your incision starts from the stereoaxillary line till the costal margin. No rib resection, you can go in between the ribs. And you, inside the diaphragm, the peripheral costal portion of the left crus and the left crus and the arcuate ligament of the diaphragm, but you should lift a part of it for future repair. And after of course you do retroperitoneal dissection, and you cut the pleura, and you do, after defining the level, you do discectomy above and below the fractured vertebrae. Corpectomy is done. You start always in the middle, and after the middle you go to the right, deep right side first, before doing the left side. And always preserve the anterior rim of the body and the right vertebral rim. That's important because you need to putting a graft here. Corpectomy is done, you have to visualize the dura from pedicle to pedicle, and the last piece of bone over the dura should be very essential and left till the end. And you put your bolts here after preparation of the bed, and you put your graft after on distraction, and there should be a clear space behind the graft or behind the cage, the vitrectomy cage, between it and the dura as a safety margin. That's the picture of corpectomy, and here is the diagram to show the clear area that should be left. We have to correct all the operative table tilt before final tightening of the system, and you close the pleura and you close the diaphragm. And that is the incision. It's about 13 centimeter incision for this. And you have to do also late follow-up. Always I like to say that the late follow-up is the best test for the approach. You have to look to the bone fusion with the bodies above and below. And you have to look to also to the bone in and around the cage of the bone graft. Good recontouring of the bony spinal canal, restoration and the maintenance of the vertebral alignment, in addition to the clear bone formation towards the spinal canal in front of the bone. For this case of L1 fracture, and we can see that canal compromise is about 70%. And here we can see that is immediate post-operatively, that is the bone graft and that is the plate in place. And this area is left for decompression, but 8 years later, the graft is almost completely fused with the body. In addition, there is a clear bone formation here, and that's going, but takes the nice contouring of the spinal canal, which is, and the height is maintained, the angulation is preserved. But despite these advantages, there are unique disadvantages of the anterolateral approach because of the learning curve and the need for help, like thoracic surgeons, dedicated surgical tools that needs, and instrumentation devices that's more expensive than that of the posterior approach. And in one study there is 11% major complications and 24% minor complications. But with good learning curve, this becomes less and less. These injuries may include the abdominal viscera, great vessels, and the ureters, abdominal wall, and the neural elements. And if we look combine the anterior and the posterior approach, it may be needed for few cases, as we mentioned earlier, but it has the advantage of improved sagittal alignment, thoraspinal canal, and the neural decompression with stabilization of the disrupted posterior ligamentous complex. That's a very nice paper about systematic review about combined antero-posterior surgery versus posterior surgery alone for thoracolumbar burst flexion. And the conclusion of that is to initiate high-quality randomized control trials for comparing the different treatment modalities, because what exists in the literatures now are weak evidence-based ones. But anterior versus posterior approach, that's multi-center study, included more than 1,000 patients. They concluded that neurological recovery was better with the anterior approach, and the anterior approach was more effective in bladder functions improvement. And this is another study that compares the transpedicular approach with the anterior approach. That's for 80 cases. And they found no significant difference between both approaches, but the patients that underwent transpedicular correctomies has greater improvement in neurological function than those who underwent anterior approach. That's comparison for antro-lateral and posterior approaches for burst fractures. For angulation, and they concluded that for angulation correction, it's better be done and be maintained in the anterior group. And the removal of retropulsed bone from the canal is better in the anterior group, and in their research the costs are equal. What about implant failure? In the form of breakage or bending or loosening of the screws. And this usually occurs around 6 months. For the posterior systems, it may be up for short fixation up to 50%. For the anterior system, it's about 11%. And the loss of angular correction, for the posterior systems, it's up to 12 degrees. For the anterior systems, it's up to 4 degrees. That's in favor of the anterior systems. Timing of surgery should be planned after optimal conditions, usually next day. But you have to consider emergent surgery for progressive and subtotal neurological deficits, especially at the coda levels. The still relevant questions should be opened, still there, and we don't have a clear answer for. Like, what about the paraplegic patients? Is it effective to do either decompression or stabilization only? And this should be done early or late. And what about stem cell applications? And what about multi-level involvement, especially if they are apart of each other? And which system is the best? Plating system or root system? I mean system profile. This should be clear. And when you should go anteriorly or to put a spacer should be in each patient or on which selected one. And to do long or short fixation, and why to do 360-degree surgery. And all this should be considered. And to conclude, until now there is no unified classification system, clinical evaluation scale or pain evaluation scales. In the reviewed studies, there was no important differences between the anterior and the posterior groups regarding a clinical radiological evaluation. The rate of complication is not different. So there is a real need for randomized prospective comparative studies level 1 with longer follow-up. It is needed to identify indication, advantages, and the drawbacks of each approach. Thank you very much for listening.
Abd-Elhafiz, thank you so much for this kindly presentation. You have summarized everything very well. We have some questions. The first question came from Mehmet Seçer from Turkey. What do you think about the thoracal fractures in Parkinson's disease? Is there another different way to treat the Parkinson's patients?
Yeah, of course. Parkinson disease is quite different, and its fractures. I think that I will resort to 360.
360.
Yes.
Very good. And another question from Fatosh Oldashi. She is asking that if the age, the lifestyle, and the profession comorbidities for the decision for conservative and surgical treatment, do you think age, lifestyle, and profession comorbidities are the factors that makes us to give a decision for the patient?
I think that these factors we have to put it into consideration for all our types of operations, not only these fracture types. Always we consider the age. If the patient is and his physical needs, if the patient is 75 or 80, of course we have to consider something different that young patients which is 18 or 20 years old. And I have to consider all that, yes.
And a question from me, Shehab-Eldien. Which
Yes,
classification system are you using in your daily practice? There are lots of McCormick,
TLIC,
McAfee, AO,
TLIC,
TLICS. Which one?
TLICS, yes. TLICS,
TLICS.
TLICS classification. I think it is very nice, almost somewhat simple, easy to memorize, and it converts informations by a good way. It defines your treatment plan and from where you should go.
But there are some disadvantages of the TLICS classification. Like if you have multiple fractures, okay, one
Yeah.
at the T12, okay, and one at the L5, okay,
L5?
L5 or L4, it doesn't matter,
Yeah.
okay. So the TLICS classification has a disadvantage there. So which classification would you take in care for the patient?
What's your opinion? You asked it. You said
I
that
don't
is
know.
not
I really don't know. There are lots of classifications, okay?
because
McCormick,
because
McAfee,
because
AO.
because I mentioned the properties of the ideal classification, but I mentioned also that till now there is no classification that satisfy all everything. So so far
Yeah,
we still don't have that classification that solve all the problems.
you're right.
You agree
Another
about that?
question. Yeah.
Yes. Yeah.
Another question again from Fatosh Oldashi. Do you advise always to include the fracture and make shorter instrumentation? Is always fusion necessary? Sometimes it is difficult in minimal invasive surgery.
I agree always we try to minimize, but at the same time, as I mentioned for short fixation, so I love to do short fixation plus index screw in the fractured level and plus anterior spacers. Of course, we have to minimize the number of the fused segments. That's why we even talk about removal of the implants after ensuring adequate fusion.
And another comment from me. I think every spine surgeon is a deformity surgeon also. The cases that fails, okay, the implant
Yeah.
failures, I think are commonly from the mistakes of the wrong preoperative surgical planning. Like the case that you have shown, there was a fracture at the thoracolumbar junction, okay?
Yeah,
They have operated that patient only one level above and one level below.
it
So,
is not my case.
no, that you have showed, okay?
Yes, yes.
It says that it will fail, okay? If you don't put
Yeah,
any anterior
and
device
anterior
or
spacer.
or if you don't length the system, it will fail. So
Yeah,
after the patient that comes to you, let's say 6 months later, this case is not a post-traumatic kyphosis. This is a new case. This is a deformity case, okay? You have to make all your plan according to the deformity.
Yeah.
And another question from Mohammed Kudir. Long
Yeah.
versus short segments. Fixation indications, please. We have talked about it.
Yeah.
Can you
But
make a little summary about it?
I can show you the slides about that,
Okay,
but
for Mohammed Kudir, he wants it again.
he wanted again. Okay, it's actually it depends on the choice of the surgeon, and it should be based on the particular characters of the patients, including the patient age, including the amount of angulation, the type of fracture, including if he's going to be a heavy worker or he will be to stay in bed and so. So I mean, most of the factors is individualized for each. But for my opinion, I like short fixation. I like to put index screw. I like to put two levels above if I have to increase the number, two levels above and one level below. And I like to insist on the anterior spacer for that if I'm going posteriorly.
And Abdul-Hafiz, do you use ligament taxis in your daily practice?
If I'm going posteriorly, then and there is canal compromise, I use ligamento-taxis. And maybe also, as I show, maybe I do interlaminar window, and after distraction, you can clear the canal. You can use bone impactors. It's beneficial, and to hammer the bone fragments backwards to its original position. But you have to do two levels above and two levels below if you do this technique. So it's long
Shehab-Eldien,
fixation.
another question. What about correction of kyphosis in anterolateral fixation?
It depends on the duration after fracture. If it is fresh fracture or if it is late presentation. And if it is fresh fractures, then it can be easy done anteriorly, as I mentioned, because of the angles, because of the anterior vertebral height is diminished and so. So I will do that. But if it is late, it will be, as you mentioned, Dr. Honor, a deformity case. I will consider it as a deformity case and treat it by the usual way, either osteotomies and whatever from posteriorly. And sometimes you need anterior and posterior for this.
Shehab-Eldien, we'd like to thank you for this nice presentation. And I want to say to the participants that you can watch this webinar again on Middle East Spine Society's website. And
Yeah.
I'm going to load this presentation on YouTube. Thank you for joining us. Thank you so much, Eldien. See you soon. We have to stop here. Okay?
Okay.
Thank you so much.
Thank you very much.